So welcome to the Penn State College of Medicine Monkeypox Echo Series. This is the first session in our series today. We're delighted to have you join us. My name is Jackie. I'm a member of the Echo team. I'm going to start us off with some brief announcements, a quick introduction to Echo. I would ask as you're logging in to go ahead and put your name and email address into the chat for our record-keeping purposes, especially if you're logged in with a name that is not identifiable. We do have a couple of other staff members from our Echo team who are logged on. And if you have any questions or problems throughout the session, you can reach out to either me or one of my colleagues, and we'll certainly help you out. So I'd like to just spend a minute talking about what Echo is, so you know what you've signed up for. So give me 1 second to share my slides. Very quick introduction to Project Echo. Just find. All right, so hopefully you're seeing what is an echo session. Caitlin, can you see that?
Not seeing anything yet.
Okay, hang on a second. Sorry, let's go back over here. How about now? Now are we seeing it?
Now it's up, yeah.
Thank you. All right. So for those of you who are new to Echo, I did see on the registrations that we have a few people who've been on Echo projects with us before. So welcome back. But what is an Echo session? I think it's more important to say what an Echo session is not. It's not telemedicine, it's more telementoring. So we're not taking over patients that you're seeing. We are helping to move knowledge, not patients. And I think the biggest difference is that it's not a webinar. COVID certainly got all of us into the webinar mindset. An Echo session is a very collaborative shared learning experience. And most of the value comes from engagement and hearing from all of the participants as well as the experts and helping to share best practices. We do use a little bit of terminology that may be different from things that you've heard in the past. We have a hub and spoke model. The down and dirty of that is the hub team is an interdisciplinary team of experts, and I will have them introduce themselves shortly. They are also identified in the chat with the head, starting with the word hub. And then everyone else, you're our spoke participants. And you can see it is a hub and spoke, so information is disseminating, but it's going both directions. Everyone here, experts, participants, hub team is here to learn from each other. What is an Echo session? This is not exactly accurate in terms of the order of things, but we always start with some brief introductions. I think the most important part to realize here is we'll have a very brief flash talk or lecture. Today, we'll actually start with that. Sometimes we may start with a case discussion, but today we are definitely starting with our brief talk. And then we'll have a case presentation and a discussion around that case. And the cases are really where we could collectively discuss it and come up with recommendations, solutions, see how things were handled. And it often complements that didactic or the flash talk. Cases are so important. We tell everyone that cases are, the heart of the Echo model. It's that collaborative learning and engagement piece. And the lecture is really the icing on the Echo cake. If you, throughout this next series, in the next few weeks that we're meeting, if you have specific cases that you would like to discuss or share with the group, you can reach out to the Echo team and we're happy to discuss those. If not, we will have cases that we're ready to share every time. And again, the flash talk, it is the icing on the cake. And I think today it's going to help set the tone for what to expect with the future series or sessions. And Gavin is going to do a great job introducing the presentation of monkeypox. So with that, let me stop that share and continue on here with a couple of quick typical announcements. So especially if you have people joining with you, make sure that their names come into the chat as well. We ask that you stay muted unless you're speaking. Also, feel free to raise your virtual hand if you want to say something. You could also put things into the chat. We'll be monitoring the chat throughout. Please remember that when we're talking about cases, no personally identifiable information or PHI is allowed. We are recording these sessions for educational and quality improvement purposes. After the session, usually within a day or so, we will share a link to all resources from the session. In the spirit of Project ECHO's all teach, all learn approach, we're always on a first name basis during our sessions. So again, today we're going to have a 15-minute flash talk on monkeypox presentation, and that will be done by Gavin. I'll give him a chance to introduce himself in a second. And then we're going to have a case presentation and discussion, and that will be led by Kat. So during both the presentation and the case discussion, feel free to put questions into the chat. We have that team of specialists, hub specialists online, and they're ready to help field questions. But remember, it's all teach, all learn, so everyone can share questions and answers. Please note that due to the nature of monkeypox presentation, some of the images that you see may be graphic in nature. So let me just ask our hub team to introduce themselves, and in no particular order. As I call your name, please unmute, tell us your name, a little bit about yourself, and why you're here on this ECHO series. And let's start with Gavin.
Thanks, Jackie. Hi, everyone. I'm Dr. Gavin McGregor-Skinner. I'm on faculty at Penn State College of Medicine, where I teach 3 graduate courses in our Homeland Security program. I'm an epidemiologist, and whether it's by luck or unlucky, I've had some experience of working with monkeypox patients in Africa.
Thank you, Gavin. And how about Kat?
Hi, I'm Kat Paulus. I'm an infectious diseases physician with Penn State Health. I have a background mostly in emerging respiratory viruses, but am now getting up to speed on monkeypox, and actually very excited to learn from some of you today as well.
Thank you. And Casey? Casey's still here? There she is.
Hey, sorry everyone. My name's Casey Pinto. I'm an assistant professor at Penn State and an infectious disease nurse practitioner at UPMC. And IT has my computer today, so I'm working from my phone. I really apologize for that.
Well, kudos to you for taking that challenge on. Thank you so much for doing that. So we're going to transition and get ready to do our presentation on monkeypox presentation. And while Kara and Gavin are getting that set up, anybody who's logged on, we would love to know why you're joining us. Do you have patients? Are you just curious? So feel free to share in the chat why you're joining us for this series.
Thanks, Jackie. So yes, I'm Dr. Gavin McGregor-Skinner. I'm going to talk to you today about the multi-cultural country monkeypox outbreak. And
hello, I'm Alawiya Solomon.
And as an epidemiologist, I'm going to talk to you about how things have changed. Next slide, please. Our disclosures, Jackie has outlined those. Again, they're here, and the webinar is being recorded today. Next slide, please. So objectives. I want you to understand by the end of our presentation today that we are here to help you. We've got a large faculty with our Penn State Project ECHO team, but for today we want to focus on, do you understand, do you know where to locate monkeypox related materials, both in the internet, on the websites, but also where you live locally? Help you understand that some of the epidemiology of monkeypox has changed, and Kat's going to have a case study where we're going to describe the clinical characteristics of monkeypox and what we're seeing in patients right now. Next slide, please. So I wanted to start with this slide. This is the CDC website for monkeypox. They've recently added schools and childcare down in the bottom left-hand corner. So if you haven't familiarized yourself with the CDC site, the address is on this slide. Next slide. But now you're going to say, well, Gavin, what have you just done to me? Because since Monday of this week, the CDC has posted 16 updates to that website. And I wanted to focus on the one that's third from the top, the print resources, because this was published only just yesterday. It includes 6 new documents that you might not have seen. And again, you can print these for use where you work. They include what to do if you suspect monkeypox, testing patients for monkeypox, monkeypox information for teens and young adults, learn about monkeypox and safer sex, reducing stigma in communication and community engagement. And then there's a template there for event organizers. So it's a letter template for event organizers to send out to attendees. Next slide, please. So for the past couple of weeks, cases have been increasing by about 20% globally. We now know there are over 44,000 laboratory confirmed cases. Again, this is now the largest ever outbreak of monkeypox. But this is what's really amazing. Cases have now been confirmed in 96 countries. That includes 89 countries reporting human monkeypox for the first time. Next slide. Here you can see a map. Now, the focus on the blue dots. The blue dots show the 7 countries in Africa that have historically reported monkeypox. Now, look at the orange dots. Now, they're the countries that are reporting monkeypox for the first time. So, for any case you see, I mean, what you see locally where you work, it's important to get a travel history, maybe within the United States, also internationally. Ask them questions like, did they have a rash or a skin lesion when they were traveling in say, a rental car or the Uber? Did they arrive at the airport, get on a plane with a rash? Or which hotel did they stay in? And as we know, the World Health Organization declared the current monkeypox outbreak as a public health emergency of international concern on July 23rd, 2022. Now, when you look at this map, yes, there are cases in Greenland. There are cases in Iceland. This geographic spread here indicates that many of the people that were exposed at an event went through an airport and got on a plane and traveled somewhere. Next slide. So the first US case of monkeypox was reported on May 7th this year, 2022. So we are about 104 days into the outbreak here in the US, and we have 15,909 laboratory confirmed cases in just over 100 days. Now, I've been looking at this data every day. Now, since last Friday, the CDC has added another 2,000 new confirmed cases. But what's interesting, California hasn't updated their cases since last week. So the weekend's happened. We're now Wednesday. Those cases are still 2,663 as they were last Friday. Wyoming was the last state in the US to report a case. All states, territories now have reported at least one case. But since Friday, and this data was updated yesterday afternoon, 23rd of August, on Tuesday, Florida added 200 cases. Georgia added 200 cases. Illinois added 100 cases. New York added 300. Pennsylvania added 70. Texas added 300. And where I live, Washington, D.C., we added 50 new cases just over the weekend. Next slide. I want to emphasize anyone can get monkeypox. It's transmitted primarily through skin-to-skin contact with infectious lesions. In the current outbreak, we know that most cases have occurred among men who acquired the infection through intimate contact or sexual contact with other men. Now, we also need to be cognizant of the fact that contact with materials, so where a person with monkeypox lesions has, their clothing, the bed sheets, the towels, carpet, toys, including sex toys, may lead to transmission. Next slide. And I want to emphasize, it is a serious disease. For most monkeypox, for most individuals infected with monkeypox, it's not life-threatening, but it is disruptive. They will not be able to go to work. It's painful. And I've seen a number of patients here in the US where, again, they have told me how painful those lesions are. And again, we know that not just it'll generate social stigma for anyone that gets this disease, and it may possibly leave scarring. Next slide. It's a serious disease, but it's also a neglected disease. So again, for the cases that I've seen previously in my work that I did in Africa, they were all in children. They were in children that were infected with contact with animals, such as rats. But this current outbreak is different. It's in adults. But we have had some children infected, and I want to be really serious here. The children cases that we're seeing here in the US, we need to investigate them thoroughly, professionally. We need to ensure that we understand how they got infected, because they probably got infected from an adult. And we need to ask those questions, as any epidemiologist would do, to ensure that we cover all the risk factors. Next slide. I want to emphasize that this is not coronavirus. It's an orthopox virus. And so we know from orthopox virus infections or even immunization, it confers immunological cross protection. So you get some degree of protection to other orthopox viruses. But what we're seeing right now here in the US is reasons for hospital admission are mainly for pain control. We've also seen admissions for break of chain of transmission. And this really depends on where the individual lives in their background. Are they homeless, or even do they live in a university dorm and we want to break the cycle of transmission? So again, we know that people with monkeypox should remain in isolation for the duration of the illness. And that's sometimes going to be very hard or very difficult to do. Next slide. There are 13 different monkeypox viruses in the orthopox family. At the top of this list, you'll see variola. Now, that's the smallpox virus. And this was a human infection, and the reservoir of the natural host was a human. But look at the other orthopox viruses on this list. They're zoonotic infections that occasionally infect humans. Now, have a look at the right-hand column under natural host. We know all of these viruses have a reservoir in nature, but as you can see in the right-hand column, for many, we don't know the natural host. And that also applies to monkeypox. Next slide. So smallpox was eradicated in the 1980s. Transmission was droplet transmission in a cough or a sneeze and direct contact with lesions. And also want to emphasize with those scabs that are on the skin. But smallpox, what we knew about smallpox was that every infection was clinically expressed in the same manner. Next slide. Now, for smallpox, there was a permanent protective immunity against future infection after recovery from the disease, which we don't know about monkeypox. So in the smallpox eradication programs were ongoing, you could carry the vaccine in your back pocket. You would then conduct ring vaccination with contacts and persons living around a person with smallpox. So smallpox was quite an easy infection to eradicate, and there was no animal reservoir. Next slide. Now, monkeypox virus was first identified in 1958 in a laboratory in Denmark in monkeys being used in experiments. The first patient was identified with monkeypox was a child in the Democratic Republic of Congo, the DRC, in 1970. Now, at that time, smallpox had already been eliminated from the DRC. Now, from a series of investigations from 1970 to 1979, majority of the patients were young children who either found or picked up some type of sick animal. There was a maximum of 3 generations of transmission in people that were unvaccinated against smallpox. So we were seeing unvaccinated parents or siblings being infected. Next slide. And the classic presentation of monkeypox during that time period was that a rash appears shortly after prodrome. The lesions develop simultaneously and evolve together. They have 5 stages as shown on this slide. They start with macules, they move on to papules, they look vesicular, and then they become pustular. Now, before they scab over and resolve, it's important to understand that those scabs, as well as the vesicles or the pustules, are infectious. Next slide. So in the 1980s, smallpox was eradicated, vaccination was discontinued, and there was concern at that time that human monkeypox might fill the epidemiological niche left by smallpox. Now, I'm going to emphasize, the presumed reservoir of the virus, the monkeypox virus, in nature is monkeys or rodents, but that's only presumed. Next slide. Now, from 1996 to 1999, there was an outbreak in Katakombe in the Democratic Republic of Congo, the DRC. It was quite continuous. It affected over 500 people. The epidemiology changed, and that's what I'm going to want to emphasize on this slide. The percentage of infections greater than 15 years of age was 85%, reflecting a decrease in people who were vaccinated, The index cases with animal contact went from 72% to 23%. It was transmitting quite easily from person to person. And when it comes to transmission chains, we were now seeing 9 generations from 16% of index cases. But the virus on genetic sequencing had remained stable since the first viruses back in the 1970s. Next slide. Then all of a sudden, in 2009, Anne Remoyne's study in the DRC, the Democratic Republic of Congo, showed that there was a 20-fold increase in human monkeypox incidence. Over 10,000 cases were reported in the DRC between 2000 and 2009, and vaccinated persons had a 5.2-fold lower risk of being infected by monkeypox. Next slide. So today, there are 2 different clades of human monkeypox, the Central African clade and the West African clade. Now, this slide shows that both clades have been increasingly dramatically recently. In 2003, the first time that human monkeypox was reported outside of Africa was here in the US. We had 47 confirmed and probable human cases of monkeypox reported in 6 US states. All the people with monkeypox in this outbreak had contact with pet prairie dogs, and those pets were infected after being housed near imported small mammals from another country in Africa called Ghana. Next slide. There have been over 18,000 suspected cases of the Central African clade between 2009 and 2019, a 10-year period, with a 10% case fatality rate. Now, people with this disease, with this Central African clade disease, are very sick, and they have a smallpox-like illness. Next slide. And yes, what has happened with the current outbreak is amazing. It's incredible that it spread so quickly, so rapidly over such a large geographical area. But we could be very fortunate that the current outbreak is the West African clade. Now, its historical case fatality rate is about 3 to 4%. And we have not seen anything like that so far with the 2022 outbreak. Next slide. So we've neglected this disease in Africa for nearly 50 years. The question remains, will human monkeypox replace smallpox? Next slide. There are research priorities and questions to be answered. Some of those questions are listed on this slide. In the 2022 outbreak, we are seeing an amplification of transmission because of a chance occurrence of genital lesions. Next slide. Reducing monkeypox transmission, we need to do better with our contact tracing. We need to identify the people who might have been exposed to monkeypox, just like the work that I've done in Africa. And then we need to ensure that we get the right communication out and we get them into a vaccination program. So again, work to be done. Next slide. And for everyone on the call today, I would highly recommend that you know where your local monkeypox resources are. The local monkeypox clinic for testing, for vaccination. What hours are they? Do you need to make an appointment? If you haven't done that, please do this after our presentation. Next slide. So again, like everything we do in infectious diseases, we need to continue effective hand washing. We'll sing the happy birthday song twice. We need to clean and disinfect the areas where people with monkeypox spend time. We need to provide personal protective equipment and that continuous training for that PPE on how to put it on, how to take it off. We also need to focus on waste management. Next slide. So when it comes to cleaning and disinfection equipment, the big take-home message today is read the label and provide training. Next slide. But the problem with the label, if English is your first language or it's not your first language, then the label can be confusing. And again, we know that the Environmental Protection Agency, the EPA, has published its list Q of registered disinfectants. There's 442 disinfectant products listed on that list Q right now that are effective for monkeypox virus, but it's very important that you focus on the dwell or wet contact time when you're cleaning hard, non-porous surfaces. Next slide. So for staff right now, we find ourselves doing lots of just-in-time training again. Employees must comply with OSHA standards and other state and local requirements. Again, we're focusing on the standards for bloodborne pathogens, personal protective equipment, respiratory protection, and managing waste. Next slide. So I wanted to finish up with some of my experiences of seeing monkeypox cases in Africa, and that's what we'd call from a perspective of clinical presentation, that's the classic monkeypox. There's the clinical presentation of classic monkeypox, that is before the current outbreak. Incubation period was 5 to 13 days. It usually starts with a prodrome that's flu-like, but also swollen lymph nodes that can be generalized all over the body or localized to several areas, like the neck or armpit. The rash appears after the prodrome, and the lesions develop simultaneously and evolve together on any given part of the body. Now, for the cases that I had seen in Africa, it was all in kids. They had lesions. And one of the things that we talked about back in May, when we started seeing cases around the world, was check the palms of their hands, because that's what we did in Africa. That doesn't apply to this outbreak. Next slide, please. So the monkeypox outbreak in 2022 is different. The pattern of the rash is scattered or localized to a body site area rather than diffuse. It starts in mucosal areas. So it's seen in genital, perianal, and oral mucosa. It may not develop simultaneously in all body areas. And a couple of important clinical findings that I want to emphasize, proctitis and oropharyngitis is being seen in many of the patients. And interestingly, in this outbreak, the prodromal symptoms can be absent or follow rash onset. Next slide. So there's a lot we did not learn from the decades of outbreaks in Africa. We are now 4 months into the current outbreak. Our focus is on multi-domain strategies for prevention. We're changing behavior. We're increasing our testing capacity. We're trying to improve the turnaround time for laboratory results. Still, where I work now, it could take 5 to 7 days to get a lab confirmation. We are ramping up vaccination. But more importantly, we then have to measure the real-world effectiveness and the safety of those interventions, including the safety of the vaccines that we might be using. Next slide. So this is just a summary of the references and resources that I used in this presentation. That's all from me today. But again, I want to emphasize the faculty here at Penn State Echo are here to help. Over to you, Jackie.
So before we transition into our case, thank you so much for all of that, Gavin. How about we spend a couple of minutes if anybody has any specific questions or needs any follow-up? I'll just give a second. You can either unmute and ask Gavin questions or pop them into the chat, and then we'll transition into our case.
Where do we find our testing centers at?
I'm sorry, we didn't hear that.
Hi, this is Adam Lake from Lancaster General. I was wondering if there's been anything more on the kind of other mutations that we've noticed in this virus, and if that's something that we're thinking about this as kind of like a third clade, because as you've mentioned, it kind of seems to act differently than what we really expected with monkeypox, and different parts of the body, and yeah, just your thoughts on that would be of interest.
Yeah, it's a very appropriate question, Adam. I'm glad you raised it. Again, we look at the speed that we moved in January 2020 with identifying the sequencing for the SARS-CoV-2 virus. I have seen some sequencing results. I haven't seen them properly defined, but I'm more than happy to share those results as they come out through our Penn State Echo platform. Where those changes have happened, again, this is a large DNA enveloped virus. It's not very complicated. It's a pretty simple virus, but I haven't seen anything specific. Other people might have that I haven't seen at the moment.
And Gavin, there is another question in here. I don't know if you've addressed it. David wants to know, does a smallpox vaccine work on monkeypox?
David, yeah, very important question. It did in Africa. We said, again, if you look at Annie's publication, which we can share with you, it's available. We saw that 5.2 decrease in risk in previous vaccinated people with smallpox. What we don't know now, and I have my smallpox scar is here on my shoulder. I got it back in 1969. What immunity I have, I have no idea. So again, this is the big question at the moment. Because we stopped vaccinating for smallpox in the 80s, what is the level of immunity right now? I think it's just unknown.
Thank you. And there's one other point here that I wanted to mention. Keisha was asking where we could find testing centers. Casey has volunteered that if you share your location or region with us privately, certainly feel free to private message us here or respond in our ECHO emails, and we will do what we can to help you find connections for testing. And if anybody does have those resources readily available, please put them in the chat and we'll be sure to share them out as well. One last question, it looks like, Gavin. When are we going to start vaccinating the general population and medical providers?
First of all, Jackie, if I just address Keisha's
Sure, please.
I have been to a number of hospitals where the staff just didn't know, and I think it's unexcusable at the moment. It's a Google search, it's a call to the health department to get those addresses. We really don't want to be, as healthcare professionals, we don't want to be in the clinic or in the hospital saying, "Oh, I don't know." It doesn't take long to find that, and I think the other colleagues. So let's work as a team, guys, and identify where those resources are in the local region we live. Going to Margarita's question, Jackie, when do we start vaccinating the general population and medical providers? There are not enough vaccines available right now. I live in Washington, D.C. I go to lots of meetings over at Congress and the White House. There is concern about the number of vaccines that we have now. You've seen that we are now giving a fifth of the dose to make those vaccines extend. We're going from subcutaneous to intradermal dosing. And again, I know that there's a lot of talk about the discussion about whether we need to ramp up that. But again, let's not forget there is a lot of adjunctive therapies outside of antivirals that we really should be focusing on right now. And I think that's important.
Another question, and we'll take one or two more and then we'll move into our case, but certainly feel free to continue to put questions in here. And if we don't address them during the session, we will in a follow-up email. Do you know, Gavin, the percentage of traditional or typical versus non-traditional atypical cases that have been detected?
This is a great question because there's been so much discussion here. And it goes really back to what Adam had raised on the genomic sequencing. Has this virus changed to become possibly asymptomatic? We don't know. What we're seeing is that in those very early macule type, the rash stage, they're not painful. They then evolve to be quite painful, and it comes down to good pain management. But right now, it's really interesting. I would see patients in Africa, and they would have lots of lesions. I'm seeing patients now with very small number of lesions. We had one last week. Look at my foot. And the lady had thought, oh, maybe I got bitten by ants when I was doing the gardening. And I said, well, do you mind if we test you for monkeypox? And unfortunately, yes, she was positive. So I hadn't seen lesions like that before. So again, this is unusual. But again, are there asymptomatic cases out there? I don't know. But as more information comes to hand, we're definitely going to share it through our Penn State ECHO forum.
So again, thank you all for these wonderful questions and continue to put them in there. There will probably be more questions in our case. Kat is ready to lead us in a discussion of a of a case. But before we do that, I'm going to launch a quick poll. So if you could just take a few seconds to answer this poll. I hope you're all seeing it. And for those who've seen me on echoes before, I strive for at least 50 to 60% participation. And you are not disappointing me. We're up to 64%. I'll wait another second or so. So have you seen a case of monkeypox? Yes or no? Right. We're at 78, 81%. Thank you so much for those who shared your responses. I will share those results now. So it looks like most people have not, but quite a few of you still have. So I'm going to stop sharing that, Kat. If you have any other polls or anything you'd like, we could do that, but I'm going to mute and let you take over.
Great, thank you so much. So it was very interesting looking at this poll, and most of you have not seen a case of monkeypox yet, but there are some of you here that have probably seen more than I have. So be very interested, for those of you that have seen a couple cases, to put what you've seen in the chat so that all of us can learn from the cases that you've seen as well as we go through this case. So I get a lot of questions looking for advice on the clinical recognition of monkeypox virus infection versus other conditions with similar findings. And this has been a learning curve for all of us because most practitioners in the United States have never seen a case of monkeypox. And so we've been learning in real time, just like we did with COVID. So this is a case that will illustrate a presentation of monkeypox. This is a case that we actually borrowed from the New England Journal of Medicine, although it's very similar to some cases that I've been involved in since we started seeing cases in the United States. This patient was a 31-year-old Caucasian male, and he came into just a regular primary care clinic. He reported a 1-week history of a painless genital rash and a 2-day history of fever and sore throat. And when the clinician went to examine him, they noted that he had this macular rash that he actually hadn't noticed right along his inner thigh. Some painful lymphadenopathy. Again, he didn't describe that. They found it on exam. And then some ulcerated lesions and several umbilicated pustules on his genitalia, which is shown in the picture on the right side. So when you were first seeing this patient in your clinic, I know there's a number of healthcare workers on the echo today. What would be some things that you'd like to know about this patient? Just put it in the chat, or you can come off of mute if you prefer. Yeah, so I see in the chat asking about fever. So he did have a 2-day history of a fever and a sore throat. Those actually came after he noticed the genital lesions. I see a very good question about a prior HSV history, none known at that time. And we're going to talk a little bit about travel in the next slide, as well as some of his social history details, which it sounds like people are curious about in the chat. So this case is occurring in the United States. The patient does identify as bisexual and had a recent condomless intercourse with a new male partner 3 weeks ago prior to presentation. Didn't know much about this male partner. He does reside in the United States, but has monthly travel to Latin America for his job. Has a history of HIV, which per report is very well controlled on Biktarvy. Only other medication is Wellbutrin. And so you're managing him in your primary care clinic. This can be for either people in the chat or for hub team members, because I know many of us see patients in the primary care setting. What would be some things that you would want to test for up front or do right away in this case? Not seeing a lot in the chat. So Gavin or Casey, what would you usually do in one of these situations?
And a couple are coming into the chat now, Kat.
Yes, I see them now. So some of the things that I would have done also if I had seen this patient, an HSV swab, look for syphilis, gonorrhea, chlamydia, any other STIs that people want to throw out there that kind of go along with that, maybe with his Latin America travel.
Well, the one that got me last week, Kat, was the ant bite. I wasn't ready for that one. Infected ant bites. Wasn't on my list.
I didn't even think of ant bites. So. Right. So I'm seeing
the point is here is that incubation period is very long, and so it's really hard on, there's a lot of bias, a lot of recall bias when trying to get back to where were you in the last couple of weeks. That's a challenge.
So I see great things in the chat, most of the differential that we would have been considering. I see molluscum in there, which is a very good thought as well. And then we did some initial testing. We did check on the HIV status. He had reported being well controlled, and he was, with an undetectable viral load and a good CD4 count. His urine GC was negative. Treponema antibody screen was negative, so ruling out gonorrhea, chlamydia, syphilis. He had an HSV PCR of the lesion, which was negative. We also did a VZV PCR of the lesion, which was negative. And so we were kind of in this situation where we didn't know what was going on. Because of the Latin America travel, he was started on empiric chancroid treatment and was planned to return to clinic if these lesions were not improving. So monkeypox was not suspected at this time. He wasn't sent home on any particular isolation. He did come back 5 days later with now a vesiculopustular lesions that included the face and hands. So much more classic for a monkeypox presentation. And at that point, the lesion swab was sent to the public health lab and testing was positive for monkeypox. Then we were able to isolate him until lesions were resolved and the contact tracing was initiated by the public health department. But thinking through this, the patient had had a week of this rash and then a 5-day delay in diagnosis. So a lot of time where he was not on isolation. 2 weeks later, without any intervention, all the lesions had resolved and he was feeling much better. And so I think the summary from this case is that this really presented looking very similar to an STI in a patient that was had a reported risk for STI. And so his primary care doctor did exactly what most of us would have done, especially prior to this monkeypox outbreak. I don't think most of us would have thought of monkeypox. And then the diagnosis really wasn't considered until the lesions were disseminated. And one of the big problems here, this patient didn't require any particular treatment, but there was a big delay in the initiation of isolation precautions and contact tracing, which is really important. And so I think, you know, we really need to increase awareness of this. We're seeing all kinds of unusual presentations. And so if you have an unusual rash, particularly in a group where monkeypox is circulating, it's safer just to get that testing done right away. And I think we'll find more and more cases as we do that. So I'm looking through the chat now to see if anybody else wants to share a case that they've seen of monkeypox, and they could even come off mute to do that. I think we'd all be curious to hear.
Yeah, hi, this is Adam Lake. So we've had a few kind of interesting cases here. One, I'll start with this one. So this is a guy that was a known contact from another patient that's at our clinic, and I called him up as soon as I heard that he was a contact, and I was like, we need to get you the vaccine because we have the stock of the vaccine here from Department of Health. And he said, is it a problem if I've had a fever the past 2 days? And I said, yes. So went through all the different symptoms, and he had some soaking night sweats and a fever and a sore throat that just kept getting worse. And checked in a number of times over the next couple of days. I even called the Department of Health trying to just empirically get him access to tecovirimat, because he's a contact. He doesn't have any lesions, so I can't test him, but he has a severe sore throat. He has a fever. He's got all these symptoms, and they wanted him seen to just kind of rule out strep and kind of other things that could also cause this. He went to urgent care then and did test positive for strep, and had a distant past history of penicillin, so they put him on Keflex. And he did start to feel a little bit better, but then 2 days later, he ends up having some pustular lesions show up on his face. He went to urgent care again, got tested, and it came back for monkeypox. His sore throat and his fevers and night sweats have pretty much gone away, but he keeps having these recurrent clusters, different places in his body, of kind of 1 or 2 pustules So it's been very challenging to actually clear him and have him go back to work because he keeps developing other spots, and sometimes they're kind of a little subtle. It's just a red macule, but not really any reason for it. So we had to watch it for a few days, and we see these recurrent sort of elements. I've not started him on Mpox at this point because he doesn't really meet any of the criteria. He's not immunocompromised. He doesn't have any genital or rectal lesions. And he's not in a lot of pain. He just has lesions.
Yeah, so that's a great case. And it sounds like your patient actually presented more like a more typical case where they started with the prodromal symptoms. We've had quite a few cases that have presented initially with lesions, and the prodrome doesn't occur, or they get systemic symptoms later, which has made it a bit challenging. We had one patient that really thought they had just acne that had broken out on their face, but had a contact that we tested. And it really did look like acne, but was monkeypox. And so I think, it's very challenging to diagnose these cases.
And I think in his case too, it was hard because as much as I wanted to test him for monkeypox just in his throat, that's not an approved way to test him. And same, we had a similar guy who just presented with proctitis, no lesions otherwise. And honestly, I ended up just doing a blind swab rectally and sent it. And then I swabbed something that just looked like a random hair follicle, and both came back positive for monkeypox. But just kind of tough when we're really being limited to only testing lesions at this point. But I know that there's validation that needs to happen.
I'm Trish Kyrese. I actually met the same clinic as Adam. And I wanted to highlight that we had a case of monkeypox in which there were two characteristic lesions, but the patient also had another lesion that, looked slam dunk for tinea and actually was responding to antifungal medication. But I had swabbed that as well, and that came back positive. So that kind of raised the question for me, well, is that really tinea and there was just some virus in that particular location, or was that a different presentation, of monkeypox? So I don't have a perfect answer for that one because I didn't do a scraping to see if it truly was, but that made me concerned about everything I see.
Jack, we've got a question there about how long does the virus live outside the body on surface? You want me to answer that one?
Casey did put some information in, but if you would like to follow up on that, you certainly can. And there is also a question from Linda about, the current variant, are we seeing, is it primarily sexually transmitted?
Okay.
Oh,
So just on the point on, sorry, Kat, you want to go? Okay, just on the point on the virus living outside the body on surfaces, there's a lot we know about orthopox viruses. It's an envelope DNA virus. It's the easiest of all the germs, microbes out there to inactivate or to destroy. There are studies on other orthopox viruses, also studies on this monkeypox virus. So we have one study where the investigators found live virus 15 days after a patient's home was left unoccupied. This study and other studies are closely related to other orthopox viruses. Yes, the virus survives in the environment. It can be on weeks or months in porous materials, may harbor the live virus for longer periods than, say, non-porous. So you're looking at bedding, clothing, carpet versus plastic, glass, and metal surfaces. And another study just came out as well, where there was 2 cases and they found that 70%, and I think they took 30 swabs from 30 different surfaces. They found virus by real-time PCR, but they didn't do any culture. So we don't know whether it was infectious or not. So the concern here is, from our perspective as a healthcare worker, the virus is going to be on bedding, towels, carpet, and it can survive in the right conditions up to weeks or months. It's very sensitive to UV light, and it's very sensitive to many disinfectants like the EPA List Q. And again, we've got to wear the appropriate personal protective equipment as well.
One question that we've come up from a practical point of view is kind of how to clear these patients to come off isolation. We've had a number of patients that have just gone back to work just because they need to go back to work, and you know, trying to walk that line of harm reduction versus you know, actually giving them what I would scientifically say, like, don't, you know, stay in isolation until things all clear up. So I guess best ways, you know, that folks have found to kind of clear folks, if it's kind of them sending pictures, or you re-examining them, or you just kind of give them general instructions and, you know, call me with questions. Just curious what folks are doing from that point of view.
Just on that, Adam, isolation is really challenging, really difficult. Here in DC with our 402 cases, some of these cases are amongst our homeless population. We have one child which wasn't hospitalized, was sent home, but how do you isolate a child? So it's very, very difficult. I really like you know, again, you've got to cover up those lesions. I'm going to emphasize that, again, that the lesions are infectious as well as the scabs. When the scabs fall off, they're infectious as well. So we've got to have proper cleaning and disinfection for those areas. Covering up, you know, you've got to cover the skin, and you know, people will want to go back to work. They want to go out and back out to a society. It's very challenging. I really like what Katie Noss shared in the chat, the Pennsylvania Health Alert Network of August 22nd. And if you look what Katie Noss has shared in that Health Alert Network, the healthcare worker guidance, it says that we have to monitor for 21 days from our last date of care of a patient. So I hope that everyone understands that's a lot of work for us to do that, but we need to do it. You know, as an epidemiologist dealing with Ebola, Marburg, COVID, and now monkeypox, I think I live most of my life here in the attic, Adam, in isolation. You know, it's nice to get on, but that's my life at the moment. But I'm very careful if I'm, even with the personal protective equipment that I wear, what I do outside of my work hours.
I got a bunch of questions. I'm happy to let other people speak, but does Mpox seem to shorten the course of infections or decrease how often you're getting that? I mean, anecdotal experience says it might, but I'm wondering if there's any evidence that you've seen that kind of looks at the overall impact.
So we haven't used Mpox here yet. We haven't had a case where we've needed to use it. There's no good data out there on Mpox yet. There are some trials getting up and running. As of right now, I have a feeling most of the data that will accrue will be more of a retrospective look of people that it was used in rather than anything randomized. We're hearing anecdotally that people get better, but you know, you always have to take that with the caveat that there's no control group.
And also in the chat, Linda Murray asked, Kat, is monkeypox variant we are seeing primarily sexually transmitted? And Casey Pinto from our team answered that. Hey, Linda, the monkeypox disease is not sexually transmitted per se, but it's been spreading through close intimate contact. That's that close skin-to-skin contact. So while we have seen this outbreak among sexually active patients, it's important to note that it's not through contact, it's not just through sexual contact. I think we all agree on that. And some of our recent cases, specifically the one that I talked about, brought up was not sexual contact at all. And again, I'm going to emphasize that there are cases in children, a small cohort of cases that need to be investigated thoroughly and professionally.
And I think one thing that we don't know yet is even though you can find the virus in things like semen, we don't know if it's actually transmitted that way at all. It might all be skin-to-skin contact. And so even though there have been a lot of sexual encounters linked to cases, it's mostly that skin-to-skin contact that we're concerned about.
Yeah. And that's a really good point, Kat, because I want to emphasize to everyone on this call, you may have to engage you will have to engage the assistance of dermatology colleagues really early. You know, like orthopox, any orthopox virus, it can lead to scarring. So don't wait. If you have patients when they first present, don't wait until it's too late. Engage your dermatology colleagues as early as possible.
I see a really interesting question about the location of the lesions having relevance to the initial contact, which actually I've been wondering as well, because, and Gavin may know better, he has more experience here, but I know that with the prairie dog outbreak, there were some concerns that bites and scratches were like the initial introduction and lesions started there. So I've been very interested to hear the answer to that as well.
Yeah, thanks, Adam. I think, and Kat, this is really important because if I go back to the cases I've seen in Africa, back in May, when I talked to my colleagues, Tim and Deb, and we said, hey, gosh, there's monkeypox again. And they said, tell everyone to check the palms of their hands, because we saw this in the kids. They were playing with these animals that were sick or dead or the feces of animals. And that's where the lesions were definitely on those palms of the hands. What we're seeing now, again, with the areas of the lesions in those mucosal areas, oral mucosal areas, perianal areas, the genital areas, again, that's the likelihood of, and again, Adam asked this question about the genetic sequencing. I've got to look for that for you, Adam, but it's really important that contact, that initial close, intimate contact is where those lesions are. And again, as I said before, we're not seeing that diffuse spread as we've seen, and the epidemiology has changed from what we saw in Africa years ago to what we're seeing in the 2022 outbreak. So it really looks like they're discrete areas, localized areas on the body where that intimate skin-to-skin contact has happened.
So I think we're getting close to the end of time. So I just wanted to take a moment to sort of recap and give Gavin a chance if he has any final thoughts as well. I think one of the great things about the ECHO platform and really the discussions today is that we're all really learning from each other. And as this outbreak evolves, we'll continue to do that. And so I appreciate all the comments from people today, giving me some further knowledge of how to assess these monkeypox cases. And I think from my standpoint, the take home of what to think about is if you see an unusual rash, particularly in somebody with a known exposure to monkeypox, or they're in a group that has monkeypox cases spreading, such as men that have sex with men, these are people that you have to have a very high index of suspicion and send that testing off. And now that many commercial labs are doing testing, it's getting easier and easier to test people. And I'll then turn it over to Gavin for any closing thoughts.
Yeah, thanks, Kat. I just want to emphasize, again, we're being challenged as healthcare professionals. I agree with what George had mentioned in the chat here. Isolation is extremely difficult. Home care, the majority of our patients, and probably you'll know this, Adam, with patients you've seen and what you're seeing in your area, they're going home, and we really have to provide good guidance and good support for home care. It's going to be really challenging in pain management, which we're going to talk more about in our Penn State ECHO series with subsequent presentations and talks and discussions. But again, it's important. Understand the local resources, where they are, what they are. Let's not be killed again by just being drowned in websites. Let's talk together as a team. Thanks to Katie Noss for sharing the Public Health Alert Network. Really appreciate that. Work as a team, guys. Share stuff. Talk to each other if we can. And let's really make sure we don't stigmatize a population. Everyone in the community counts.
Thank you for that, Gavin and Kat and Casey, for contributing, to everyone for your engagement, especially Adam. Thank you for sharing that case. You will be receiving an email very shortly, which contains a link to the session evaluation. Please complete that. If you're requesting CME credit for your participation, you do need to complete the evaluation in its entirety. But even if you're not claiming CME, please share your feedback so we can continue to ensure that these sessions are meeting your needs. We also always want to improve. I did put a note in the chat. Any questions that were not answered, we will provide responses to in our follow-up resources. We'll also summarize everything. And ironically, our next session, kind of piggybacking on what Gavin just said, will be risk factors and stigma associated with monkeypox. So that session will be on September 7th. We look forward to seeing you then. And again, please watch your email and have a wonderful rest of your day.